I want to thank the panelists. That was really a great overview of a couple of different sides of the healthcare system. You heard Paul give a broad overview, and then obviously the tribal system has quite a few differences with that, and then to move into the wraparound services, and then close out with community health workers. I think gives us a pretty broad view of what's out there, and what's striking about it is. There are some commonalities, obviously. All are dealing with limited infrastructure and the financial structures to support them are not necessarily there. But then there are also some significantly big differences, and it affects how they're structured and how viable they are moving forward. But really a great view overall. And we've got a number of questions that have come in, so we'll go right to that. And the first question is, be interested in what people think about how they're dealing with COVID-19 and how we're treating mental health with our youth, and with senior citizens. So anybody on the panel have a thought about telehealth and its use to reach children,
Yes.
so they're not vulnerable, and also the elderly?
Yes, and so this is Dan. So as I mentioned, in that facility that we have a behavioral health wing that allows support, and that is really engaged at almost the 90% in terms of capacity and what they were seeing prior to COVID and what they're doing now. So the telehealth component for them has really been a saving grace and a large boon for the community, because not only can the adult clients, but also the pediatric clients can also access care. The primary issue with some of the pediatric clients is, of course, the observation component. So that goes both ways. If you're not able to really see within a room, but the other positive is that you get to see them in their home environment. So that is a plus in terms of behavioral health and the pediatric component of that.
And what's the patient reaction to that from your experience?
So it varies. It can be frustrating, for individuals because of the platforms and the limited capacity that we have in some of the areas. So really thinking outside the box in terms of the other platforms and bridging between visits, whether it be some of the non-secure FaceTime or Zoom modalities, and then scheduling further on. So that frustration, does come from that part of it. But I think the other side of it is clients do enjoy being in their home environment, and they're able to be a little less formal when they have that surrounding them and their visit.
Yeah, very good, very good. Any other perspectives from the panelists on that question? All right. I think this next question probably teed up for Paul, but others may have some thoughts too. I think this also has, this also has very definitely has a tribal element to it. But given the financial challenges of small rural and tribal hospitals and the closure rate, the question was, what research do we need in advance to figure out which hospitals are most at risk or likely to face closure, and what's the relationship to COVID-19 and creating that risk? And then as you think about that answer, what needs to happen beyond just basic reimbursement changes and pilots to really accelerate this in a way that addresses it for the long term?
I'll take a shot at it and then let one of my colleagues give the definitive answer. When you're looking at systems that are fragile, financially fragile, if you will, or vulnerable, it doesn't take much to tilt the scale. And so that's what we were looking at. There wasn't a lot of reserve in a lot of these more financially vulnerable rural facilities and practices. I don't want to just talk about hospitals, but any stressors that come along, like canceling outpatients. Most of our rural facilities are 60, 70, 80% outpatient business because they don't have that much inpatient business. And so it was not only an immediate, but a hard whack on their finances. There's also the fact, though, that at the same time that this was happening, we were hearing conversations about it from the urban areas that what are we going to do to deal with this surge that we're having? aha, there's those underutilized rural hospitals. And the concern that came to me at that point was, well, they may be underutilized when it's a matter of something elective or something that you can plan. But when these rural folks begin getting sick with the COVID, they're not necessarily going to go immediately to that upstream hospital. They're going to go to the nearest ER. And so I was concerned, number one, that we might be looking at surge capacity that wasn't really there, as far as taking on. The second thing I looked at is an underreporting of what was really happening in rural that really gave me concern. I was looking at these charts on the daily briefings from the White House, and I was seeing these curves going up and everything. And I thought, they're still down low in rural, but they're just because they're to the right of the chart and they're not showing yet. And that was my concern, that the capacity would be there in the rural areas when it hit there. We're starting to see that now for a number of reasons. For the reasons that I talked about, the disparities that have been long existent, well, they're coming home to rest now when they get stressed by the virus. And so seeing that is the concern that the resources would be there. I mean, I've run a rural hospital and I could find all of our PPE in one drawer in one closet. And that's the realities that exist. And the other realities that exist is these smaller facilities are usually at the end of the food chain, or the supply chain, if you will. And so those were all concerns that I had, that will we be ready if and when the surge does come? And what will we see? How much of this bypass that rural has become accustomed to is going to disappear when it comes to the crisis of the pandemic? Let me pause there and just let my colleagues weigh in on some other things that they've seen.
Dr. Kalick, how would you answer that for tribal hospitals and the financial status they're in?
So as you will know, there in terms of the capacity for such an event as this, the capacity is very limited. And I like the analogy of the example of the closet with all the PPE located, or a drawer with all the PPE located, and that was essentially a very good description of what people were perceiving as a state of readiness. Now, and the Navajo and the Arizona situation has been well highlighted, and I think that bears a very good spotlight about a situation gone very awry, and the need for better processes around the state of emergencies that may exist further on. But each area is very different. In Arizona, there's one situation. In California, it's another. With over 33 million people in California and over 60 different tribal entities just within the state, it does pose another example. I was going to comment on the issues with hospital closures and how they're affected. And so in some of these areas, like in Texas, where there's border towns and the hospitals adjacent to these border towns, there has been a very interesting influx across from the border within Mexico, and translating United States policies and procedures around distancing, around health literacy, and having those shared across the border, even within the areas. Southern San Diego County has a much higher rate versus northern San Diego, and that's that can be attributed to the proximity to the border. So I think there's a variety of components in looking at the research around that, and how geographically distinct it is depending on the populations and the proximity even to international concerns.
Yeah. So given both of those, go ahead.
I was going to say, everything that I think has been said already, I totally agree with. We have issues with rural, Native American health, with disparities, financial instability. I want us to zoom out for a second and maybe even put together into this basket all of the challenges in the healthcare system in the United States. And it seems to me that a good 70, 80% of all of these challenges stem from a chronic underfunding and chronic underappreciation for public health. And we're asking more so of vulnerable facilities as a result of this chronic underfunding, underappreciation for public health. I hope that the COVID-19 experience is really going to allow for the political and the, necessary timing to rethink some of these things that continue to plague us. Regardless of who's in office, it's the same story. If I came to, this webinar, assuming it was broadcast, 20 years ago, we would be talking about the same issues. In 20 years from now, we will be talking about the same issues, unless we deal with that bigger picture that seems to be creating all these problems that are dealt with compartmentally rather than holistically. So I'm curious if others agree.
Well, it certainly speaks to what Dr. Probst talked about, the urban structuralism argument from this morning. And you're right. The question was about rural hospitals, but pick your provider type really, and it all comes back to financing. So what does the future? Well, what would it look like? To get to the questioner's second point, which is, you can increase reimbursement by a small percentage. You can tweak things here or there, but ultimately we're back in the same boat as you just noted. So what's the path forward?
I don't think tweaking reimbursement per se is the thing, because reimbursement implies medical care reimbursement, not healthcare reimbursement. We do a better, but not a fantastic job at providing medical care services. We do a pretty crummy job at keeping people healthy or keeping people's diseases, once diagnosed, from becoming worse. So we need to infuse health back into the way we conceptualize healthcare. And in most people's mind, it just means better medical care. Give someone an insurance card. Yeah. That doesn't solve their life problems that are exacerbating their health. That helps them cope with it better, but it's certainly not the most cost-effective way to deal with it.
Yeah, good point.
Right. And
any other panelists want to weigh in on that?
Yeah, I would like to weigh in. I think one of the major issues that we have with rural healthcare and seeing all these rural hospital closures and things along those lines is financing is such a big deal in our healthcare system. It's profit maximization. It's where's the money going to come from? And quite frankly, doing a lot of healthcare work in rural areas is not necessarily as profitable as running some large urban hospital might be. And we need to recognize that some of the incentive structures might need to be a little bit different to make sure that these, not just the health needs, but also the social determinants of health are being addressed in these rural communities. Because as things would get worse as opposed to better, as these rural hospitals are going to close, it increases distances to care, it causes other problems. So as long as the paradigm in our current healthcare system is focused on profit maximization, it's going to lead to more and more problems in rural areas as opposed to less.
Good point. Yeah. Well, let's lean into another question we have, which I think speaks to wraparound services, but also links to your work, Tim, and that is, so there's less take up in rural areas, and yet, it's such an important part of addressing the social determinants. We had one question that said, this would seem to be a really important resource, whether it's community health workers or other wraparound services for people, especially as they travel long distances for specialty care, but then come back to the rural community, and can better use of wraparound services and CHWs help ensure that that care is coordinated.
Yeah, so let me jump in there first. Community health workers easily fit the definition of wraparound service providers, no question about that. And there's a growing literature on them. I left them out a little bit from my analysis, in part because the ones I focused on are licensed individuals or credentialed individuals that require some kind of schooling or some kind of additional training above and beyond what a community healthcare worker would get. I would argue community healthcare workers are increasingly being used, and based on Tim's work, as generalists in rural areas. That's part of the issue. Because there is a shortage of the traditional wraparound service providers there, you have to get people who can be trained quickly from the community to do the job of, a half a dozen other professionals that in an ideal setting would be able to do so with a lot more resources. And so although that is true, and that's probably a good path forward because it's the path of least resistance, it is also problematic in the sense that it continues to generate, I guess, what Janice Probst was describing as urban structuralism. That's another example of it. We can't fix the problem of getting the, more heavily trained individuals there. And so we'll burden less trained people with more challenges.
Yeah.
Yeah, I think that's a great point. And there's actually sort of an interesting fight. At a minimum, a debate within the community health worker community over training and education. And many, in fact, would say they don't want that training and education because they want to feel that they're part of that community. And that by getting that training, they're actually removing themselves from being a member of the community and making them sort of an other. So that's sort of an interesting dilemma that's going on there. But related to the actual question that Tom posed, I think, there is certainly a role for these wraparound services. So let's say you go to the large urban hospital to get some sort of treatment and then you're brought back to your local community. I think that, there's certainly a role to be played in the local community for these wraparound services, whether it's by community health workers or others. But I think that requires care coordination to be developed between urban areas and rural areas. And I don't think we necessarily see that. You'll see care coordination between the large hospital in the city and then, the community health workers within that city. But if you're going from the urban area to the rural area, I think that care coordination might not be there to the same extent.
Yeah. We had one other question I wanted to bring up, and that was one of the greatest strengths that tribal nations and rural areas have that policymakers need to be aware of that perhaps they're not aware of.
I'll weigh in on that one. I think it was mentioned earlier today in one of the presentations, but I have a favorite saying, and that is rural areas are resource restricted, but they're relationship rich. And I believe if you turn some of these communities loose with an understanding that, we will lay the paved road and the high lines to the edge of your property, but it's your responsibility to get it on up to the house. And that's one part of Jan's illustration in her picture that she showed. And growing up in rural areas, I know who was responsible for the last quarter mile of line, and that was the property owner. There is that sense of community, and I believe that they will do that. But I being a Fed, I'm not supposed to have an opinion on this, but I believe that Jan really hit on some issues there. We need to know, we need to value. And then there's the point where that the market driven, there are places in this country that the market model is just not going to work. The market model says you squeeze more efficiency out of the system by putting more volume in. That's not a solution that rural has to offer, putting the more volume in. There is another solution though, is that you squeeze more efficiency out of it by avoiding potentially avoidable utilization. And that's where you bring in the community health workers. That's where you bring in the social services, and you deal with things ahead of time before they become those expensive medical issues. And I believe that's part of that last quarter mile. It's part of getting the electricity up to the house, up the driveway. And I believe communities will step up and do that because of that relationship rich thing they have going on.
Yeah,
About that in tribal, Dr. Kalik?
Yeah, I have to concur with Paul. And it's that component of resiliency that's persisted in these communities, and the social structures that have allowed people to really rely on each other has been a very strong foothold, and to allow them to continue to climb up, against a very steep gradient in terms of healthcare, health access. Unfortunately, if we spin that around 180 degrees, it's probably one of the biggest Achilles heels that we have to really guard against in terms of pandemics. And so that social structure, that community base, that you're already dealing with an individual community who is already isolated, and now you want them to stay home and be further isolated. It really has to be dealt with, very delicately in terms of advising people, again, with at-risk health literacy, in terms of why you would have to stay home and those issues surrounding that. But I agree with Paul. The ability to tap into that social stream of resiliency to allow them to persevere in these times is very important. And thankfully, the other part of it, in terms of the community health workers and the wraparound services, as a physician, I rely so heavily on those services, because I only see individuals for 15 minutes, but if I can send out a public health worker, a public health nurse, if I can send a dietitian to do telehealth with a client, then it really extends out my ability to provide a better level of care for a community.
It sounds like everybody's coalescing around the fact that these wraparound services, the coordination, the community health worker really are essential to population health, given the infrastructure we have. I guess the question I have for Dr. Menachemi is, why is there so little real research on this? Is it a numbers issue? Is it just a bias on the part of the research community that it's just easier to do this in urban? Why don't we know more about this sector in the same way that urban areas do?
So, up until we've been talking about population health actively, in part because it's been incentivized by changes to the reimbursement, it's never even been a real thing in our medical care system or in our healthcare system. All of these, by the way, you go to almost any other country that's developed, social workers do not deal with healthcare issues, they deal with social issues. In this country, they're forced to deal with lots of the patches. They're patching up the imperfections of our system. And that's kind of going back to the other comment I made. We have this underappreciation and underfunding that's chronic in public health that's causing all of these other problems. In most other countries that have well-organized and well-functioning healthcare systems, medicine and public health are two sides of the same coin, not totally different animals with different structures, different training. I mean, most people in the medical care delivery system do not interact with their local public health agency, do not necessarily interact with their state agency unless they have to report something that by law they're required to. There's so much room for partnerships, for innovation, which, to Paul's point before, is one of the strengths in rural America. Those relationships means there's trust, which means I'm willing to put my neck out to try something because we both agree it's the right thing to do. And so I'd love to see a way to capitalize on those relationships and that trust in a way that we can do it in the reverse, figure it out in rural America and scale it up in urban areas.
Okay. I couldn't agree more. Is it your sense that are there good data sources to better understand the social service support structure that you've been researching, or is it hard to get at that from a quantitative standpoint?
I don't know. We need that much more research on the social determinants and their impact necessarily. I think we need.
I meant more on the support services.
These professionals do what they are trained to do, and it turns out it works. I think the focus is on how do we get more of that scaled up in the areas that we need. And so implementation science plays a role in helping them understand that. Health services research plays a role to understand that. But we have to address the elephant in the room that right now, figuring out how to fund these individuals through charity, philanthropy, grants, that's not sustainable, as I think Tim made a strong argument for. This needs to be built into the bedrock of how the healthcare system in these communities are organized and evolve. And if not, then again, we'll be back in 20 years complaining about the same stuff.
That's a great point. Great point. So tomorrow, I think we'll be able to. This will tie up nicely to what we're going to talk about tomorrow, where we're going to focus more acutely on the population health efforts session, and then how the health and human service sectors can really come together and interact, collaborate with the goal of improving health. Any other comments from any other panelists? All right. Well, hearing none, I just want to thank you all for your presentations. They were great. I think they set us up nicely for tomorrow, and I appreciate everybody hanging on for the afternoon session, and we look forward to having you back tomorrow.